Hi, welcome everyone to our Cecilia Health webinar. Thank you for joining us. We might see a few more people trickle in, but I'd like to go ahead and get started. So welcome, I'm Emily. Nanette will be the pharmacist diabetes educator who will be presenting tonight, and we'll be talking about all the medication tips your doctor didn't have time to tell you. So welcome, I think it will be a really exciting conversation here. Just to let everyone know, in case if you are having any technical difficulties, you'll see they're listed in the bottom left corner. There is a phone number, 800-263-6317. Yes, please reach out if you have any issues with that. But thank you again for coming tonight. All right, next slide, please. Let's see. All right. Here we can go ahead and get started here with that. You will find here, are we, Nanette, there we go. Thank you. Sometimes we have technical difficulties ourselves, so thank you so much. So everyone, you're going to find that the format for our program is a presentation, and then we will have an interactive discussion at the end. And what you're going to do is you'll type a question using the question section of the webinar toolbar, which is off to your right for most of you on your screens. And so at the end, if you have a chance to ask any questions, please write those in, and Net will be able to answer those as well with that. All right, great. All right, and just as a disclaimer as well, we know that the information that you are about to hear may motivate you to make lifestyle changes. Please consult your physician before making any changes to your current routine. And the Cecilia Health Certified Diabetes Care and Education Specialist will provide strategies to help you manage your diabetes. And this online Q&A session is intended to give general advice. This information is not a substitute for personal medical advice and involves it involves the professional opinion of the Cecilia Health CDCES. All right, so here as we get started tonight, Nanette Sabel, she is our Cecilia Health Certified Diabetes Care and Educational Specialist. She's also a pharmacist as well. And just a little bit more about her, she is a pharmacist who left retail and became a Certified Diabetes Care and Education Specialist. She's been with Cecilia Health for 8 years, and in the summer she likes to volunteer at a diabetes camp for kids, and she loves watching movies with her husband of 30 years. And in addition, she enjoys quilting, spending time outside gardening, and as well as bird watching. So thank you everyone again for joining us tonight. And Nanette, you have the floor. Thank you.
Welcome everyone, and thank you for spending part of your evening with me. I am Nanette Sabel, a pharmacist and a certified diabetes care and education specialist. Tonight we are going to talk about all the medications for diabetes, the oral medications, the non-insulin injectable medications, and insulin. And again, talk to your healthcare provider before making any changes to your diabetes treatment plan. We're going to talk about how the medications work, the recommended dosage, the advantages, possible side effects, cautions and warnings, and the percentage of A1C impact they'll have on your blood sugar. Now, I know that when I'm watching TV, every other commercial seems about some medication for something or another. And I wanted to explain in the beginning, why are the diabetes ones on TV? back in 2008, the FDA passed a law saying that for all diabetes medications currently existing and going forward, they wanted to make sure that the medications themselves do not increase the risk of us having a heart attack, stroke, or congestive heart failure. And in fact, no, none of them have shown to have caused any problems. Actually, some of them have been shown to have some cardiovascular benefits. And I will mention these on the specific medications as we go through. And as a side note, in 2018, the FDA said, gee, do we need to still have drug companies do this? And they came back with yes. So as long as there's additional benefits on the medications, I have a feeling we're going to keep seeing the commercials. So there's oral medications, injections that are not insulin, and then insulins. So now these are the different drug classes, and these names kind of talk about more so where the drugs work in the body. I wouldn't expect somebody to say, hey, I want to start on an SGLT2 inhibitor. But if you're talking to somebody who knows what an SGLT2 inhibitor, you know that drug works in the kidneys, as an example. So we're going to talk about biguanide, sulfonylureas, DPP4 inhibitors, SGLT2 inhibitors, thiazolidinediones, glucosidase inhibitors, and meglitinides. And there's also one oral GLP-1 receptor agonist. Now, first we're going to talk about metformin. It's also known as glucophage, Glumetza, or Fortamet. And metformin actually works three different ways. The main way is it decreases the amount of glucose that's released from your liver. And it was approved back in 1994. And the average person with type 2 diabetes, the liver is releasing 3 times the normal amount of glucose. Now, metformin helps cut that amount down, and that helps improve your blood sugar. It also helps the muscles use some of the sugar from your blood, which is going to decrease your blood sugars. And in an additional way, it also prevents some of the carbs from being absorbed from your intestine. I want you to put a pin in that one. It's recommended that you start metformin at 500 milligrams once a day and you take it with food. And over time, your provider should increase you to 1,000 milligrams twice a day. Now, it's recommended to be taken with the last bite of the morning meal and the evening meal. And that reason is recommended to take with food is to prevent the most common side effect, stomach upset. Now, if you're taking it with food and you still have stomach upset, talk to your provider. And there is an extended release formulation of metformin. The extended release should still be taken with food, but it dissolves at a slower rate, and so you don't have the stomach upset. And there's multiple advantages with the metformin. It's inexpensive, it doesn't cause weight gain, it doesn't cause hypoglycemia or low blood sugar. And an additional benefit with this type of medication is it can decrease cholesterol. Now, research has shown that metformin may have the potential to decrease the risk for heart disease. Now, the most common side effects are nausea, bloating, diarrhea, headache, vitamin B12 deficiency. And again, the extended release can help with the GI-related side effects. Your doctor should periodically be doing blood work to check your levels of B12. And with the diarrhea side effect, that's where, because metformin is preventing some of the carbs from getting absorbed, the carbs have no place to go, and that's kind of where part of that side effect can come into. Now, metformin can lower your A1C by up to 2%. So if your starting A1C were to say be 10%, and once you were able to take the maximum dose, metformin alone could bring your A1C down as low as 8%. Now, American Diabetes Association recommends an A1C below 7. So if metformin was your only medication, it would make sense that the doctor would want to add on a second medication to help bring your A1C to goal. Now, the 2% decrease is what the medication at the maximum dose can do. If you increase your activity and eat 3 balanced meals a day, your A1C can be decreased even further. So now we're going to talk about sulfonylureas. and they've been around since the 80s. The generic names are glyburide, glipizide, and glimepiride. And these drugs work these drugs tell your pancreas to release more insulin, and they can be taken either once or twice a day. The most common side effects are weight gain and low blood sugar. And because the medication is telling your pancreas to release insulin, you shouldn't miss any meals. If you do, or if you're late for a meal, it can increase your likelihood of having a low blood sugar. Another caution with this medication is sulfur allergy. If you have a sulfur allergy, you may be allergic to this medication as well. An additional caution is sun exposure. When you're taking sulfonylureas, you want to make sure that you use a strong sunblock and reapply it often, because taking this medication can cause you to burn in the sun faster than you would normally. And they've also been found neutral for heart disease, which means they don't make it better, but they don't make it worse either. And sulfonylureas can lower your A1C by up to 2%. Now, the next class of medications are DPP-4 inhibitors, or dipeptidyl peptidase 4 inhibitors. And the brand names are Januvia, Onglyza, Tradjenta, and Nesina. Now, people with type 2 diabetes have too much of a hormone called DPP-4 in the stomach. And this medication helps you decrease the amount of DPP-4. And because now you have less, the pancreas is allowed to release more insulin when you eat. And this medication can also help you feel fuller sooner, so you eat less. Now, it has a low risk of hypoglycemia or weight gain, which is always good news in my opinion. This type is neutral for heart disease. You only have to take it once a day. And common side effects can be headache, sinus infection, and disabling joint pain. And they can lower your A1C by up to 0.8%. Now let's spend a minute talking about side effects. And I'm not just talking about side effects to diabetes medications. I'm talking about any side effects, because I'm a pharmacist and I talk about this stuff. If you experience a possible side effect to a medication, it's always recommended that you talk to your doctor and let them know what you're experiencing. If it's something that the doctor wants to change your medication, most of the time we have another medication that he can change you to. And it's safer for you to let your doctor know sooner rather than later. And it doesn't necessarily always mean an appointment, especially with online messaging with your provider. So it's important that if you're having a side effect, to talk to your provider. So let's move on to the SGLT2 inhibitors, and this is the sodium glucose cotransporter 2. And again, these are working in the kidneys. The brand names for these are Invokana, Farxiga, Jardiance, Stellectro, and Brenzavvy. And in people without type 2 diabetes, when blood sugar becomes elevated around 180, the kidneys will help lower the blood sugar by excreting the sugar through the urine. With type 2 diabetes, this doesn't work as well, and the body doesn't excrete extra sugar in the kidneys until blood sugar is much more elevated, like 220 or even higher. So when you're taking SGLT2 inhibitor drug, it's helping your body get rid of extra glucose through the kidneys sooner. Now, this medication is meant to be taken once a day. And Invokana, Farxiga, and Brenzavvy have been shown to help preserve long-term kidney function. And there's a low risk of low blood sugar. There's no weight gain. There may even be some weight loss. And they can also help with high blood pressure. Invokana, Farxiga, and Jardiance can reduce the risk of cardiovascular death, heart failure, and preserve the long-term kidney function as well. Now, because these drugs cause more sugar to flow through the urine and bladder, that's where most of the side effects occur. You may experience bladder infections, increased urination, or yeast infections, and these can occur in both men and women. And diabetic ketoacidosis is rare. And these can lower your A1C by up to 2%, and there can be a several pound weight loss as well. So now on to the thiazolidinediones, or TZDs as they're often called. We have Actos and Avandia, also known as pioglitazone or rosiglitazone. And these drugs help your body be more sensitive to insulin, in particular in fat and muscles. And they also decrease the amount of glucose released by the liver. Now, it can take up to 12 weeks before you see the full benefit of these medications. And Avandia is taken once a day. Actos can be taken up to 3 times a day, and they can be taken with or without food. Now, with side effects, the most common ones are headache, sinus infection, swelling, or fluid retention. And caution should be used if you have liver problems or congestive heart failure. There's also what they call a black box warning on these, which states that they may cause or worsen congestive heart failure, so weight gain and swelling should be monitored daily by the patient. And they can lower your A1C by up to 1%. Now we have the glucosidase inhibitor drug class, and these brand names are Precoce or Glycet. And they're also called acarbose or miglatol. And these drugs work by delaying carbohydrates from absorbing from your intestine, which keeps blood glucose lower. Now, the glucosidase inhibitors are taken before meals, and they should be started at the lowest dose and increased every 4 to 8 weeks if needed. And slowly increasing the dose will help decrease the GI-related side effects. Now, weight gain and low blood sugar are the most common side effects, and when you have a low blood sugar while taking one of these, you need to treat the episode with glucose tablets. Other types of treatments will not absorb in a fast enough manner, and it's recommended that these be used cautiously in people with liver or kidney problems, and they can lower your A1C by up to 1%. And the next drug class is meglitinides. And so we have Prandin and Starlex, or repaglinide or netglinide. These medications stimulate a rapid insulin burst, so it's important to take before meals, so you take it up to 3 times a day. And the side effects include low blood sugar and weight gain, and they can lower your A1C by up to 2%. So now I'm going to talk about Rybelsus, and this is one of those that you probably saw on TV. And the active ingredient in Rybelsus is semaglutide. Now, it's a GLP-1 receptor agonist, and it's a tablet. The full name is glucagon-like 1 peptide receptor agonist, and it's an oral version of Ozempic injections, which I'll talk about that in a minute. Now, people with type 2 diabetes don't have enough of a hormone in their stomach called GLP-1, and what we do have gets broken down very fast by another hormone called DPP-4. So we have almost no GLP-1. Rybelsus works by increasing the amount of GLP-1 in the stomach, and it's designed not to be broken down by DPP-4. Therefore, the pancreas can release insulin when blood sugar is elevated, helps you feel fuller sooner. Now, because most people with diabetes don't have much of the GLP-1, these medications are always started at a starting dose for 30 days to help your body get used to having that hormone. And then after a month, it's increased up to a dose where you'll see more blood sugar control. So in this case, you start at 3 milligrams for 30 days, and then you would go up to the 7 milligrams. If you need more blood sugar control than the 7 milligrams, then your provider can increase you to 14 milligrams a day. Now, again, it increases GLP-1 in the stomach. It allows your pancreas to release insulin when your blood sugars are elevated, helps you feel fuller faster, and that can help with weight loss. Now, the most common side effects are nausea, vomiting, diarrhea, and headaches. And again, starting at the low dose for a month can help the body get used to having more of this hormone, and the dose increase as you start to see a decrease in blood sugars. Now, the FDA says that Rybelsus reduces the risk of heart disease, There are contraindications for this kind of medication, and it's if you have family history of MTC or medullary thyroid carcinoma, or MEN2, which is multiple endocrine neoplasia syndrome type 2. If you develop hoarseness or a throat lump, contact your provider. And if your vision changes occur, notify your physician. So now let's talk about injections that are not insulin. So these are also GLP-1 receptor agonists like the Rybelsus, but these are all injections. And so we have 6 of them on the market. The once-a-week injections are Bydureon Precise, Trulicity, and Ozempic. The once-daily injections are Victoza or Adalimumab, and the twice-a-day injections are Byetta. And again, people with type 2 don't have enough of the gut hormone GLP-1, and so you inject this, it replaces that. It doesn't get broken down by the DPP-4 like the natural occurring one does. Therefore, the pancreas can release insulin when your blood sugar is elevated, and it helps you feel fuller sooner. Now, the most common side effects, nausea, vomiting, diarrhea, headaches, and again, they need to be started at a low dose to help your body get used to having more of this hormone, and the dose should be adjusted every week or so as you can tolerate it. Now, for cardiovascular benefits, Victoza, Trulicity, and Ozempic have been shown to reduce the risk of heart disease. Bydureon, Byetta, and Adalimumab doesn't increase the risk of heart disease. You have contraindications of family history of MTC or MEN2. Contact the provider if hoarseness or throat lump develop, and the risk of thyroid C tumor with Victoza. So now we're going to talk about Mounjaro. And Mounjaro is called a dual incretin agonist because the one molecule works like 2 different hormones. It works like a glucose-dependent insulin-tropic polypeptide receptor and also like the glucagon-like 1 peptide receptor agonist. Now, it decreases how much you eat. It slows down how fast your stomach empties. It decreases glucagon levels because a lot of times the pancreas will release glucagon when you don't need it, and that's increasing blood sugar. It helps your body use insulin more efficiently. It can lower your A1C by up to 2.4%, and you can have weight loss by up to 25 pounds, 17 to 25 pounds. 17 pounds is at the lowest dose. The higher dose, you get potentially a 25-pound weight loss. Now, Mounjaro is used once a week in a single dose pen. You start at 2.5 milligrams that you inject once a week for a month. And this molecule is different than all the other molecules, so no matter what else you are taking, if you're started on this, you start back down at the 2.5 milligrams once a week for a month, and then you're increased to 5 milligrams, and you need to be on that for at least a month before there is a dose increase. And with the side effects, nausea, which is why you should be started at the lowest dose for 4 weeks, diarrhea, injection site reactions, also the contraindications of family history of MTC or MEN2. Any hoarseness or throat lump develop, contact your provider, and avoid a family history of medullary thyroid tumor. And they're working on determining how Mounjaro is with heart disease. So now on to an amylin mimetic. We have one of these. It's called Simulin or Pramlintide. And I like to think of this as insulin's best friend. They work together. People with type 2 diabetes don't make enough amylin. So injecting amylin before major meals, we're able to replace what our body isn't making. And with more amylin in our body, it decreases the amount of sugar the liver releases. Our stomach slows down how fast it empties, and that helps feel fuller sooner, and our blood sugar doesn't increase as much. side effects: headache, nausea, weight loss, temporary loss of appetite. If you use it with insulin, the insulin dose needs to be adjusted to prevent low blood sugar. Doses are 60 to 120 micrograms injection before major meals, and it can decrease your A1C by up to 0.8%. Now let's talk about insulin. Now, insulin is the most effective treatment we have for lowering A1C. There is no limit as to how much the A1C can be lowered. And because some of the insulin comes in pre-filled pens and some of the vials, they're categorized as far as how fast they lower blood sugar. We have rapid, regular, intermediate, and long-acting. Dosing of insulin is very individualized, should always be started at a low dose and increased over time to the effective dose for that person. There's no universal dosing with insulin for anything. It should be based on what you need. And keep in mind, like with oral medications, increased physical activity and balanced meals are still part of the use of insulin. So I'm going to start out talking about long-acting insulin, which is basal insulin, then intermediate acting, short acting, rapid acting, also called bolus insulin, and ultra rapid acting. And I want to explain how different insulins work together. Before you had type 2 diabetes, you had background insulin always floating around 24 hours a day. We would call that a long-acting or a basal insulin. When you would eat before type 2, your pancreas would release insulin, bring the blood sugar down, and then you would have the long-acting insulin floating around. And the combination between people using long-acting in mealtime, we are trying to replicate what we used to do. So with the basal or long-acting insulins, we have Lantus, Basaglar, Toujeo, Levemir, and Tresiba. Now these are usually injected once a day, sometimes twice a day, usually last for about 24 hours, and they control your fasting blood sugar and your between meal blood sugar. Now, most common side effects: potential of low blood sugar or hypoglycemia and weight gain. Now, one little side note about Levemir. The manufacturer of Levemir has decided to not make it anymore. The Flex pens will be discontinued by the end of April, and the vials will be discontinued by the end of December 2024. Now, with intermediate acting insulin, Novolin and Humulin N, or sometimes it's called NPH. And this is the one insulin that's cloudy. And this usually lasts for about 12 hours, so you would inject it about twice a day. It's less expensive than the other insulins because it's been around for a very long time. Because it's a cloudy insulin, before you use it, you would roll it in your hands to make the cloudiness more consistent before you draw out your dose. Most common side effects: low blood sugar and weight gain. Now we have bolus or short-acting insulin that are regular insulins. We have Novolin R, Humulin R, U100, and Humulin R, U500 vials and pens. And the Novolin, Humulin R, those are been around a long time, inexpensive. The Humulin R U500 is 5 times as potent as the U100. So those are used in very specific cases. Now, these lower blood sugar after meals. Ideally, you want to inject the insulin 15 minutes before the meals. And with the U500, most often if you're on a U500 insulin, that's the only insulin you need because it's so concentrated, you don't need a second one. It does the actions of both the long and the short acting. So now we have rapid acting, or bolus, sometimes people call it mealtime insulin. And these you want to try and inject 15 minutes before you eat, so up to 3 times a day. And that's Novolog, Apidra, Humalog. Admelog is a new biosimilar to Humalog. And they last about 4 to 5 hours per injection. It lowers your blood sugars from the meals that you ate. And again, possibility of low blood sugar and weight gain are the most common side effects. Now we have ultra rapid acting bolus insulin. Now, because it's ultra rapid acting, you can inject it right before you eat, like when the food's in front of you, kind of as fast as that. It lasts for 3 to 5 hours. It lowers the blood sugars from the meals, but it's over and done with a lot faster than the other insulins. And the most common side effects are, again, low blood sugar and weight gain. Now we have one inhaled ultra rapid acting insulin, and that's called Afrezza. And Afrezza comes in these cartridges with an inhaling unit that you put the cartridges in, and it comes as 4, 8, and 12 unit cartridges. And again, this would be mealtime insulin. It gets absorbed through the lining of your lungs. The lung function should be assessed before you start on Afrezza. Avoid in anybody with lung disease that increases your risk of having a bronchospasm. So nobody with asthma, exercise-induced asthma, or COPD. Possible side effects are low blood sugar, cough, and throat irritation. For the cough side effect, it's recommended you have a sip of water before and after you inhale the Afrezza. In order for you can't use this in anybody who smokes. For somebody to smoke who would be a candidate for this, they would have to stop smoking for at least 6 months. Now, across the board, all insulins are neutral in regard to their effect on heart disease. So let's talk about where you should inject insulin. So it's recommended anywhere in the abdomen. You need to stay at least 2 inches away from the belly button or any scars. You can inject in the back of your arm between your shoulder and your elbow. In your thigh, you want 4 inches or about 1 hand's width above the knee and at least 4 inches down from the top of the leg. The best area is the top and the outer area of the thigh, and you don't want to inject into your inner thigh. There's too many blood vessels and nerves there. And you can also inject in your wallet hip, in the hip or the wallet part of your hip, but you don't want to inject in the lower buttock area. When injecting with an insulin pen, you inject straight in and be sure to hold the pen in a few seconds after the insulin is delivered to ensure that no insulin leaks out, and you never share insulin pens with anyone. I would recommend that you ask your doctor for the shortest needles available. For insulin pens, they're 4 millimeters long. For syringes, they're 6 millimeters long. Exercise that occurs immediately after the injection may speed up absorption because of the increased circulation in the injection site. So if you plan on strenuous physical activity shortly after injecting insulin, you don't want to inject an area by the exercise. So if you're planning on playing tennis, don't inject in your racket arm. And if you plan on going for a jog or run, don't inject into your thighs. So when you're injecting medication on a regular basis, you need to continually rotate sites, and that's going to help prevent scar tissue from building up. And you want to keep them about 1 inch or 2 finger widths apart. And you don't want to inject in any scar tissue or any areas with broken blood vessels or varicose veins, and scar tissue can interfere with absorption. Now let's talk about medication adherence. Now, I know it's challenging to always remember to take medication, but when it comes, I hope some of these tips will help. I would suggest buying a week-long pill box. Some people like to get two so they can have one for morning meds and a second one for the evening medications. You can also buy medication baggies, and they can often hold more pills than the pill boxes if you have larger medications. If you have a phone, you can always set an alarm to help you remember to take medications. You can also keep a small supply in your office or your bathroom. If you want to keep some at your office or in your purse, I would encourage you to ask your pharmacist for a second bottle with the label for the medication on it, so there's no confusion. I wouldn't recommend keeping more than a little bit in the bathroom because of the high moisture and increased temperature. It can impact potency of the medication. And restock once a week so you always have the fresh medication. And then if you have a smartphone, there's now apps to help people remember to take medications. So now I want to take time to answer any questions you might have. Simply use questions section of the online seminar tool to the right of your screen, and I'll try and answer as many questions as possible. Okay, here's one. What do I have to do to get off all of my medications for diabetes? Yeah, that's a good one. So let me review that managing type 2 diabetes, it's recommended you eat 3 balanced meals a day, not too many carbs, not too little carbs, and you need to be active 30 minutes a day most days of the week. Now, burning blood sugar by way of activity and the medication keeps the medication at a minimum. That said, if food and activity are not at the correct levels, there's a bigger emphasis on taking medications. Now, when, let's say you get to a point and the doctor says you don't need medication anymore. Still recommended you check in with your doctor at least once a year to make sure everything stays where it is. Okay, here's another one. I heard everyone ends up on insulin. Is that true? Well, no, not everyone, but type 2 diabetes is a progressive disease, and we only have so many beta cells in our pancreas to release insulin. And how many beta cells you have is going to be different than how many I have and how many different the next person has. So once they're gone, we don't get any more. We have no way of making more. And so when your pancreas gets to the point, if it gets to the point where it doesn't make any insulin at all, then you have insulin as an option for that person. And keep in mind, it's the most effective drug we have to improve blood sugars. Okay, it seems like my doctor is just picking a drug for me. Is there any reason why he's choosing what drug for me? So there's guidelines that recommend different drug combinations, and these guidelines are recommended, they're modified throughout the year. And the doctor probably isn't randomly choosing a drug, although it could seem that way. He's probably choosing a drug that's going to complement what you're already taking. And, at one point we didn't have SGLT2 inhibitors. And now that we do, they're going, oh, this is a good way to lower blood sugar. And it can help with weight loss. And it can help with blood pressure. So if you're not sure why your doctor's picking the drugs for you, ask him. It's allowed. You're supposed to know, and you can say, hey, what benefit do you see with me taking this medication? Obviously, I'd expect him to answer something about blood sugar, but, is there a benefit to your kidneys? Does he see a benefit for your heart? Ask. It's your body. I would expect you to ask questions and know the answers. Now, here's one. It seems like my pharmacy never has my injectable medication. It's not an insulin, but I don't remember the name of it. What can I do about that? So I know with the drugs like Victoza, Ozempic, Mounjaro, Trulicity, that those are all running into inventory problems. And I'm sure the drug companies are trying to do everything they can to get more product to the market. There's not a whole lot you can do. You can ask your doctor if you have samples. You may be able to change from one product to another, but that means you need to go back to the starting dose and work your way back up. Unfortunately, there's not a lot of options. You can, if you go to one large chain, you can try and go to another large chain to see if maybe their supplier might have some, but that's not necessarily. I don't know if, a lot of times only certain pharmacies take certain insurances. So I wish I had a better answer for you. I just know that all the drug companies are working on it, and they don't like not being able to provide you with the medication. Okay, now it looks like we're about out of time. I want to thank you very much for joining us today. And I apologize if I didn't get to your question. If you're interested in our upcoming webinars, you can ask your coach about them. We have one in March about stop focusing on what you can't eat and learn about what you can eat, healthy eating and diabetes. And we also have that in Spanish in March. And in April, we have Say No to Diabetes Complications, Say Yes to Reducing Your Risk, Keeping Kidneys, Nerves, and Eyes Healthy. If you want to attend more events, talk to your clinician. Simply reply to one of their emails and they'll share all the available events online. You want to receive text message reminders? If you haven't signed up for text messages, ask your clinician. And the more great diabetes information and tips, follow us on Facebook, facebook.com/Cecilia Health.
And we just want to say thank you again, everyone, for joining us tonight on behalf of Cecilia Health. And Nanette, thank you so much for giving us all a lot of good information as well. So thank you, everyone, and have a great evening. Bye-bye.